Good afternoon, everybody. My name is Sharice Magoon, and I am with UT Health School of Nursing. You are signed in to hear Dr. Kowalchuk present MAT 101, and we are happy to have you join us for the Texas NAS Awareness Month. These free CE presentations are sponsored by Texas Health and Human Services. Before we get started, I just want to go over just a couple of housekeeping items. We do ask that you mute your microphones at all time and turn your video off. We will take question and answer via the chat, and Dr. Kowalchuk will prompt us when it's time to do that. Without further ado, I would like to introduce you to our presenter today, who's Dr. Alicia Kowalchuk. She is an associate professor with Baylor College of Medicine's Department of Family and Community Medicine, and is board certified in both family medicine and addiction medicine. She is medical director of Insight, the SBIRT program for the Harris Health System, Santa Maria Hostel, a substance use disorder treatment center for underserved women, and the Houston Recovery Center, which operates a sobering center in partnerships with the City of Houston and the Houston Police Department.
¿Tienen otros headsets?
Dr. Kowalchuk, whenever you're ready.
Great. Well, thanks and welcome everyone to this lunchtime talk, and hopefully we can be somewhat interactive even through Zoom, or maybe especially with Zoom. So please feel free to use the chat function throughout, and every few slides I'll stop and see if there are questions via chat. And then I'm hoping to wrap with a good 5 or 10 minutes at the end for us to dialogue off chat as needed. So we're going to start with a couple poll questions just so I can see who's with us today and where you're at in terms of understanding medications for treating opiate use disorders, and where we might focus today.
All right, I'll launch it now.
So it looks like we're fairly stable with our poll results now. It looks like from our poll results that many of you are in behavioral health, perhaps nursing, but don't have a DEA registration. So looking to get more information about medications for treating opiate use disorders to help your clients or patients, but likely not going to be prescribing yourself. So that's helpful for me to know when we're talking. A few of you are interested in becoming waivered. That's awesome too. And then most of you seem to be very aware of the benefits of medication treatment of opiate use disorder during pregnancy. But hopefully this will be a nice review of that for you as well, and maybe some new information. All right, so I'm going to move on from here. We'll end polling. Thank you very much. I don't have any disclosures. You already heard a lot about me, so I won't belabor that. And let me go to slides. So we are going today to, by the end of this, be able to list FDA-approved medications for, let's stop sharing results, for the treatment of opiate use disorders. Well, just a minute, everybody. Discussing the treatment of opiate use disorders in the preconceptive, pregnant, and postpartum periods, describing ways to decrease the stigma of opiate use disorders and medication treatment in pregnant and postpartum patients. So that's our focus today. Okay. So just a little bit about the opiate epidemic nationally, and I'm going to make this brief because I believe most people on today are very familiar with the opiate epidemic, but just a reminder for us that opioid overdose in general is still the leading cause of death for people under 50 in the US. The peak seemed to be 2017, at least so far, at 72,000 deaths. We saw a slight decrease in 2018. That's the latest data available from the 2019 National Survey on Drug Use and Health, which came out last September, October. So we'll expect an update about the same time this year. And again, some comparisons to that in terms of other major causes of US casualties. And my computer is lagging a bit. I apologize for that. So a little bit about the perinatal opiate epidemic from a more national perspective. So you can see that neonatal abstinence syndrome has been rising every 25 minutes. So while we're here together, at least 2 newborns will have been diagnosed with neonatal abstinence syndrome. And you can see that from 99 to 2014, so over those roughly 15 years, we had a very significant, over 4-fold increase in the number of deliveries to mothers with an opiate use disorder. And you can see some of the latest National Survey on Drug Use and Health data as well. We have seen a slight decrease over the last couple years, which is good, but we're still not where we need to be with that. Okay. A bit about where we're at today, which is in the midst of a pandemic, along with an epidemic of opioids. So there's some predictions or theories out there about what we're going to see once more data is available about what we should see in terms of drug use trends, specifically around opioids. We are predicting an increase in substance use and overdoses. Folks in recovery, isolation in particular, can be a big trigger for relapse, as can stress, and a lot of folks in general, and of course folks in recovery are under increased financial stress, increased stress of caretaking, etc. We're also predicting a change in what's available in terms of the illicit drug market, because routes of distribution of illicit substances have been interrupted somewhat by the pandemic. And so we are anticipating changes in that. And so folks may be transitioning to a substance that's more available in their community that they're not used to, and that always can leave folks at risk of overdose in particular. And then we're also seeing or predicting a decreased access to care as people lose jobs, lose their insurance access, and within the treatment community, seeing some limitations arise around accepting new patients, going to all virtual treatment modalities, et cetera, which is often new for a lot of treatment providers, though not all. I did want to present some very preliminary, this is from Houston Fire Department data on overdose incidents that they responded to. And you can see that this actually is just January 1st to March 31st, so fairly early in the pandemic for Texas in general, and Houston in particular. And you can see that we've seen a 31% increase in calls related to overdoses year over year in that 3-month time frame, the first quarter of 2020. So I don't have obviously the second quarter data, but this has us all a little nervous in our local community. And again, we're anticipating seeing some national trends as well with that. So just important to keep some of the epidemiology in mind as we move through this. So treatment for opiate use disorder, medication treatment is the gold standard treatment for opiate use disorder. And that's because we know that 4 out of 5 folks with opiate use disorder will relapse chronically without medication treatment, particularly maintenance treatment, where they're on a medication for 3 to 5 years is the what our existing literature suggests as minimum effective dose for medication treatment. But there are ongoing studies looking at year-long treatment programs and then taper. We know under a year, we pretty much do not see increased rates of sobriety and decreased relapse long term compared with just medically managed withdrawal, where folks are going through maybe some medications initially to help with acute withdrawal symptoms, but they're off of all medication treatment within a week, to 3 weeks. And so we have methadone maintenance, which is only available at licensed opiate treatment programs, buprenorphine maintenance, which is available through any waiver clinicians, and also many OTPs also offer buprenorphine maintenance now. And then agonist maintenance therapies. So that is methadone and buprenorphine are the gold standard treatment of opiate use disorder in pregnancy. And so we'll spend the bulk of our time talking about agonist MAT. I do want to mention naltrexone. It's an opiate antagonist that has been shown in head-to-head clinical trials with methadone and buprenorphine to be as efficacious at keeping people sober and in recovery long-term. We see decreased opiate use. The caveat is that compared head-to-head with agonist treatments, so agonist medications include buprenorphine and methadone, we see decreased rates of retention in treatment, and particularly early in treatment, a bump in the suicide risk. And there are several now NIDA clinical trial network studies supporting those findings. But people that are successfully engaged and get through the initial few months of naltrexone treatment for their opiate use disorder tend to have as robust recoveries as those on methadone or buprenorphine. Naltrexone, it is not indicated to start people who are pregnant on naltrexone, but if someone is already doing well on their naltrexone and becomes pregnant, with monitoring, it is okay to continue naltrexone. So a little bit about why medications for treating opiate use disorder. And I want to go back. We'll take a pause here for any chat questions that may have come up or not. Charisse, have we had any chats? Nope. Okay, great. So we want to talk about the pleasure reward center and what's going on in the brain of someone who has an opiate, who has developed an opiate use disorder. And the big highlights of this slide is showing the brain basically cut in half down the midline, and you are looking at it side on. And really, I want to highlight the pleasure reward center and where it's located at in the brain. And you can see it's not located in the front part of the brain, what we call our cerebral cortex, and here the prefrontal cortex. It's not located in the base part of the brain, kind of what controls our breathing and things like that, very basic functions, neurological functions to keep us alive. It's located in this midbrain structure. And that's where our pleasure reward center lies. And that's where the substances of addiction really hijack the system and make fundamental changes to the system in people that develop use disorders. And again, we're specifically focused on opiate use disorders today. And so the big part of this is that this part of the brain developed evolutionarily wise ahead of our thinking part of the brain, our conscious part of the brain, the prefrontal cortex and the cortex. And so it was always designed to kind of override this thinking part of the brain to keep us surviving. So this part of the brain is where our drives for thirst and hunger, when we're starving, when we are at, we don't have access to water, etc., live, and our sex drives live here too. And so this part of the brain was designed to keep us alive and meet our basic needs. And that's what gets hijacked, this pleasure reward center with various addictions, particularly as we're talking about opiate use disorders. And so there's lots of connections between that have developed between the prefrontal cortex and the thinking rational part of our brain to help us control and modulate this more primitive part of our brain. But again, with addiction, we're really seeing that drive to use be as strong as the drive to get food if we're starving, or access water if we are very thirsty and don't have access to water. So that's the point of this slide. And this is kind of what we used to know back in the late 70s, early 80s. I was an 80s kid. And many of you that were around back then may have remembered this public service announcement about your brain on drugs, and the guy cracks a raw egg into the pan and fries it. And so your brain was fried. And that's kind of where we used to be decades ago about understanding our brains on drugs. This is a better understanding and picture, and more nuanced picture of what happens with the brain on substances. And you can see here, this is a time-lapse functional MRI scan of a person who is ingesting, this was actually cocaine, not opiates, but we see this similar activation with opiates. And this time lapse is over the period of about 30 minutes. And you can see this is the brain resting in a more neutral state. And as substance reaches the brain, we see activation of this pleasure reward center in the brain. So here the person is feeling what we would call high, and the effects of that substance. And then as the substance leaves, we see less activation overall throughout the brain. So that doesn't probably seem surprising to anybody, pretty straightforward. But I think the biggest piece of this slide is the difference between this person's brain activation when they haven't used, pre-use, and then right after use. And you can see that after the high has worn off, the brain is not going back to baseline, at least initially. This person is not just no longer feeling high, they're feeling out of sorts. They're feeling like they're coming down and crashing. And so that's often what drives the cycle of developing addictive disorders and use disorders. This feeling here, and knowing that continued use or repeated use can get you back feeling here. If not just here. So many of my patients with opiate use disorder who have been using for more than a year or two will describe their use mostly just to get here. It's very hard for them often to get even high. They're just trying to use to not be here and to be quote unquote normal again. This is just another way of looking at it. You see a brain. And again, we're highlighting that pleasure reward center and the normal activation of that pleasure reward center in someone who doesn't have a use disorder, someone who's using with long-term use and development of a use disorder, and without substance on board. You can see that this part of the brain is less active, and so these folks aren't feeling very good. And then with treatment, we're hoping to restore normal function to that part of the brain. And so this is where medications come into play, particularly our buprenorphine and methadone. Just schematic just goes through. Okay. So I wanted to stop and see if there's any chat questions right now. And chat. Yes. Some questions. You have them. Great. No worries.
None yet.
Okay, good. And we're going to go back. I've mentioned methadone. Methadone is a full opiate agonist. We'll talk a little bit more about that later. It is available for treatment of opiate use disorder only in a licensed treatment facility, an opiate treatment program. And so it does have limitations in terms of access to care. and then a pretty substantial regulatory burden within that. So I wanted to focus today on buprenorphine. It is a partial opiate agonist. What that means is it turns on the opiate receptor to about 50%, and whereas methadone and other full agonists, so those would be things like heroin, hydrocodone, etc., turn on or activate the opiate receptors 100%. It was originally used for pain, intramuscularly or intravenously, and it's still used sometimes for that as well. And buprenorphine and buprenorphine products are the only drugs approved for the treatment of opiate use disorder outside of a licensed opiate treatment program. So this is what we have to work with in terms of agonist or partial agonist therapy for treating opiate use disorder. It comes in two basic formulations. Of course, there's lots of different doses, and there's now lots of different brands, branded products. It comes in a combo product, and that is buprenorphine combined with naloxone. Naloxone, a brand name for naloxone would be Narcan. And so most of you that are familiar with naloxone or Narcan know it as what we use to reverse opiate overdoses. It actually is an opiate antagonist. It binds to the opiate receptor and basically binds to the opiate receptor and does not activate it and blocks opiates from binding. And so why would it be paired with buprenorphine, and how does that work? So we know that buprenorphine is taken either under the tongue, in the cheek. There's a transdermal product which is not FDA approved for opiate use disorder. It's used in pain, but some people use it off-label for that. But primarily for treating opiate use disorder, buprenorphine is put inside the inner cheek or underneath the tongue and absorbed that route through the mucous membranes or the linings of the mouth. And that is because if you were to swallow buprenorphine, what little is absorbed in the stomach is processed out by the liver before it ever reaches the brain. So it doesn't work if you take it by mouth and swallow it. Naloxone is not well absorbed under the tongue. And so the idea of combining these two is that if you were to try to get high off buprenorphine by injecting it rather than taking it as prescribed, you would get the effects of the naloxone and block the effects of the buprenorphine. And so it was designed to discourage intravenous use or injectable use of this product. We still are primarily using the mono product, which is just buprenorphine alone without naloxone in pregnancy. Some people use the mono product in non-pregnant clients or patients. It tends to be a little cheaper. And the combo product has been shown to decrease diversion a bit. And so a lot of us in treating opiate use disorder with buprenorphine products will prefer the combo product for that reason. But some folks still use the mono product as well. So a little bit about the regulations and how we got to where we are with treating opiate use disorder in outside of opiate treatment programs. There is legislation called DATA 2000, Drug Abuse Treatment Act. It allows qualified physicians and now clinicians to use anyone with a DEA number to use a Schedule 3, 4, or 5 narcotic approved for opiate dependency treatment by the FDA outside of a treatment program. And so that was passed in 2000. That's where the 2000 comes from. And October 8th of 2002, Subutex and Suboxone were the first branded products to receive FDA approval for treating opiate dependence at the time. That's now opiate use disorder. Both are Schedule 3 medications. So all buprenorphine products are Schedule 3 medications, so they fit this regulation. Okay. Since DATA 2000, we've had additional regulations that now have allowed for nurse practitioners and physician assistants who have DEA numbers and go through additional training to also be able to prescribe. So we've already talked a little bit about how buprenorphine works. It is a partial agonist. It hits the mu-opiate receptor, which is the mu receptor is what gives the high, or activation of the mu receptor gives the high with opiate use. It's less of a high, particularly for those who are physically dependent on opiates, which is almost all of our clients or patients with opiate use disorder are physically dependent on opiates, on their opiates. So it causes less of a high than a full agonist, which would be something like methadone or hydrocodone or heroin, for example. But it causes enough receptor activation in most patients or clients. It helps alleviate withdrawal and cravings. So it controls those things. There is a ceiling effect. So what that means is because it only activates the opiate receptors to 50% over a certain dose, which is generally 24 to 36 milligrams a day, we see very little additional activation of the opiate receptors because they're all maxed out at that 50% activation. So there is that ceiling effect. So it does bind stronger to the opiate receptor in the brain than any known full agonist opiate, including methadone, hydrocodone, heroin. It is metabolized in the liver. It's excreted in the feces and urine. And there is a first pass effect. And what that means is it's not effective if it's swallowed. So our bodies have a circulatory system or a blood system that is where your blood from your stomach goes first to the liver before it goes to the rest of the body. And so it is very effectively metabolized in that system, what little is absorbed, and that means it never gets to the brain if it's swallowed. But it does get absorbed sublingually or under the tongue, and that allows us to dose it not through not using a needle, which is how it was originally developed for pain treatment. And then we tend to see milder withdrawal syndrome than we do for a full opiate agonist like methadone. Because again, the receptors are only ever to 50% activation, not 100. Okay. And I just want to check the chat. Okay, can you talk a little bit more about how buprenorphine is used outside of O2Ps? Yes, so we're going to get into who can prescribe it and how it's being used now. And then there's some questions about MAT and morning sickness, and is buprenorphine misuse common? So I'll address the last one first, buprenorphine misuse. So there is a street value to buprenorphine. Most of the my patients or clients that I've talked to really don't endorse that a lot of folks are getting high off of buprenorphine in the community. Most are buying it illicitly from the street to try to self-detox or self-treat, or because it is 24 to 36 hours long lasting, if they can't afford enough of their opiate of choice to get high for the day, they may use buprenorphine product to stave off withdrawal for another day or so before they can get the money to use their drug of choice again. So yes, there is a street value, but it's not commonly misused as used for self-treatment. And then for pregnant women who are in medication-assisted treatment and have morning sickness, this requires coordination with their OB, but there are medications to help with morning sickness during pregnancy that there's no contraindication or there's no bad reactions if they're used in conjunction with medication-assisted therapy. So a woman, particularly if their medication therapy is more triggering of their nausea or makes their nausea, their morning sickness worse, they can be pre-medicated or take their anti-nausea medicine 20-30 minutes before their medication therapy, and that can be helpful. The other thing about particularly about Suboxone or buprenorphine products, they are absorbed under the tongue, but there is some residual, usually saliva, mixed with, in terms of the film, if they're using the film product, the remnants of the film after all the active medication has been absorbed, still lingering there. And we find if people spit that out rather than swallow it, that can help with the nausea as well. So some patient considerations for buprenorphine therapy. So someone that's on buprenorphine therapy, unlike methadone, which is dosed in person at the opiate treatment program daily, at least until they have some time in doing well in recovery when they can earn their take homes. This right away, the person usually is able to go home with medications. It is not dosed in person after the initial start of the medication. So they have to be self-motivated enough or have another support person to ensure they take the medication. If they don't take the medication, it's not going to work. If they're either physically dependent or have another use disorder with something that suppresses the nervous system, so things like alcohol or benzodiazepines like Xanax, Somas, etc., that's relative contraindication to using buprenorphine. We certainly want to address these other use disorders or this other dependency because just like a full opiate agonist, a partial opiate agonist does somewhat slow breathing, particularly at higher doses if it's in combination with other things that can slow breathing. So we want to try to avoid that if possible. The risk is much less than a full opiate like methadone or heroin or hydrocodone, but it's not zero, and so we want to be careful with that. We certainly hope that our patients, our clients starting this therapy that have co-occurring mental health disorders, that those are stabilized or that we're working closely with them on that. And then the ability and willingness to safeguard their medication is a big issue as well for patient considerations. Okay. I'm sorry about the lag. So clinician requirements. So there are a number of requirements to become a waivered clinician to be able to do this work with patients, clients. So educational requirements, you can be subspecialty boarded in addiction medicine or certified in addiction medicine by ASAM. Now there's the ABAM boards. Or which most people come to this, even if they are otherwise addiction medicine certified, by completing a special training to be a waiver clinician. And there's free training available in person and online, and I have resources at the end for that. The minimum training out is 8 hours for MDs and DOs, and a 24-hour training for nurse practitioners and physician assistants. And so even though I've met these criteria, I still completed my 8 hours of training to be familiar and have the most information about the medication. You must, as a clinician, have the ability to refer patients to appropriate counseling services either within your own practice or more often through community linkages. You must have a valid DEA registration. And then once you complete your training, your 8-hour training, you complete a filing of notice of intent for your waiver to the DEA. And with that, you have to state that you are able to make those counseling referrals and that you've completed the educational requirement. And then there are additional limits to the number of patients you can treat. So the first here, you have your waiver. You can treat at maximum 30 patients concurrently. That means once you've begun treatment for 30 patients. Unless one patient drops out of treatment with you, you can't take on any new patients. And then after a year and reaching your 30 patient limit, you can apply to go to 100 patients. And after that second year and you've reached your 100 patient limit, you can apply to go up to 275 patients, but you can't go beyond 275 patients. The idea behind this, and this was written into, at least the initial was written into the Data 2000 regulations. We originally capped at 100 patients, and in the last couple of years, we've been increased to 275, was that the goal of Data 2000 was to integrate opiate use disorder treatment into primary care settings, including OBGYN settings for prenatal pregnant women and postpartum women, and not to create new separate treatment programs that just did buprenorphine treatment. So the idea was this is integrated into your current work, either in your addiction medicine practice or in your more traditional medical practice. And so we've already talked about limits. Counseling and buprenorphine. So it's important to think about the counseling modality, the frequency, having good communication with the physician or other clinician that's waivered and prescribing the therapy. And we'll talk about special considerations. So we do know that counseling is an essential component to long-term recovery. It can help patients address stigma of taking medication. So some of the stigma that you've probably heard, and I've certainly heard a lot of, is, you know, you're trading one addiction for another, you're just substituting. We'll talk a little bit later about labels and the importance of language, and a little bit about 12 steps as well. There's methadone anonymous more historically, and now there's medication assisted treatment anonymous programs, and we'll talk about that later as well. Counseling can really help with adherence issues to medication, and help patients and clients that are on treatment figure out when they want to go from maintenance to medical withdrawal, if they want to go at some point to that. So cost of treatment, I know for most clients and patients, that's a big concern. It is covered by Texas Medicaid, and actually most private insurers now cover it. And total costs vary depending on the dose, the daily number of pills or films required, as well as the cost of office visits and counseling. Roughly, the doses are anywhere from $8 to $12 for a pill or film, and most people stabilize between 1 and 3 films or pills daily. So it can range from $300 to $900 a month for out of pocket if someone's paying out of pocket for the medication. And so with starting buprenorphine, people need to be in mild to moderate withdrawal to start safely, to avoid triggering withdrawal. And what that means is if a person is still high on an opiate and not in mild to moderate withdrawal, that means their opiate receptors are probably at anywhere from 70 to 100% receptor activation. Remember that buprenorphine only activates the opiate receptors to 50%, and it binds tighter than all known opiates to that receptor. So you give someone who's still high on opiates buprenorphine product, and right away the buprenorphine kicks the opiate that's in their brain off of that opiate receptor, and they drop from 70, 80, 90, 100% receptor activation to 50%. And what our bodies feel is withdrawal is that drop in receptor activation. And so they'll feel like you made them worse instead of better with the medication. And that's not what we want to do. Instead, if someone is already in mild to moderate withdrawal, so their opiate receptors are 20–30% activated only, and so they're starting to have some withdrawal symptoms, and we give them buprenorphine, that increases their opiate receptor activation to 50%. And at 50% receptor activation, most people with opiate use disorder feel comfortable. They don't have cravings, they don't have withdrawal, they just feel okay. They feel quote unquote normal. And so that's our goal. And we try to gradually increase the dose until we see the withdrawal symptoms and cravings go away. And this can take several days to several weeks. Typically, we start buprenorphine, or historically have started it in the office. And so patients come, they know they're going to be there for several hours to half a day. We document that they're in mild to moderate withdrawal, give them their first dose in the office, and monitor their withdrawal symptoms and how they're feeling over the course of several hours, sometimes giving additional buprenorphine doses as needed until they're feeling better. And then we give them a prescription to go home with until we see them again, which can be anywhere from several days to a week later, when we would readjust dose and check in on the patient. Now, many people, and I know I certainly, that's my primary method of practice, is most of my patients have either known someone who's been on and used Suboxone or buprenorphine products, or themselves have tried buprenorphine in the past, either from the street, or they've been on buprenorphine maintenance therapy before. And so I'm very comfortable with at-home starts where we go over when they should take their first dose to avoid what we call precipitated withdrawal, or going into withdrawal because you take it too soon to using your full opiate. And then we do follow up after that. Okay. Stabilization, those continued dose adjustments as needed to minimize side effects and maximize craving reductions. And again, the typical stable dose range is 12 to 24 milligrams. We really see that ceiling effect at 32 milligrams. And 24 to 32 milligrams is very minimal effect as well, and increasing that dose. So most providers will stay to a max of around 24 milligrams. The minimum effective dose in the literature is 6 milligrams. And then frequent weekly contact is very common, but not usually daily contact with the prescribing clinician for the first month or so of treatment. And then those visits are spaced out as people enter more mid and long-term recovery. And then there's also work to engage the patient in counseling and other non-pharmacological treatment modalities. In the maintenance phase, patients usually are doing quite well. They don't need a lot of dose adjustments, and typically we decrease patient contact with the prescribing clinician to from weekly to monthly. And there continues to be ongoing engagement with other treatment modalities. And then after a time in treatment, some patients do want to be medically supervised in their withdrawal from buprenorphine. Although again, our literature currently supports at least 3 to 5 years of maintenance therapy, and there's no really contraindication to longer-term treatment with this medication if patients are doing well with it. So there's some special considerations going from methadone to buprenorphine, or vice versa, pregnancy, psychiatric comorbidities, etc. And I'm going to speed things up a little bit. Methadone to buprenorphine is a bit difficult because you're going from a full opiate to a partial opiate, and methadone has such a long half-life of 24 to 36 hours. And so, again, this is more specialized care and is not as commonly done as buprenorphine to methadone. So what if you have someone who continues to use and struggles with sobriety or their treatment goal on buprenorphine and max therapy? We recommend strongly at that point, to many patients that perhaps, you know, at 50% receptor activation, their brain is so physically dependent on the opiate that they are still having withdrawal and craving. And so buprenorphine is just not going to get them where they need to go. Some people need more of the structure of a methadone treatment setting, an OTP, where they do come in for daily accountability. And so that change is pretty easy to make once a patient gets a treatment slot. So changing to buprenorphine to methadone is pretty smooth. But you do have to transfer the patient's care if you're not in an OPT TP to an OTP. In pregnancy, the buprenorphine mono product is preferred. Methadone is still considered standard of care as well. Buprenorphine is pregnancy category C. It is fine for patients to breastfeed with it. And then there are several studies. The mother studies suggest that neonatal abstinence syndrome is a bit milder with buprenorphine versus methadone. So in prenatal patients maintained on buprenorphine, their infants tend to have shorter courses and milder courses of NAS compared to those who were maintained on methadone. But it is not certainly 100% that infant born to a person who was maintained on buprenorphine or methadone will get NAS. So not every infant will develop NAS, and generally the NAS severity will correlate with whether they were on buprenorphine versus methadone, a little bit milder with buprenorphine, and on dose. But it is not always the case. So I've, when I worked in an opiate treatment program, which I'm no longer part of an opiate treatment program, but when I was, and taking care of patients who were prenatal and postpartum, we would see patients on, 120 milligrams of methadone and an infant with little to no NAS, and other patients maintained on 60, 70 milligrams of methadone with significant NAS. So it was more common to see NAS at higher doses, but it was not 100%. And with both buprenorphine and methadone, we often have to increase the dose in the third trimester. As patients will report cravings and withdrawal symptoms, and that's related to increased maternal blood volumes and increased metabolism in the third trimester of pregnancy. So in labor, we're going to focus on the prenatal and perinatal component of this. In labor, regional pain management methods such as epidural is preferred. And again, just a mention of naltrexone. So it does block the opiate receptors, reducing craving and reward. And so a person has to be through opiate withdrawal and off their opiates for 7 to 10 days before you can start this medication. You also have to monitor liver function with this. And so you have to be a little careful if someone has underlying liver disease. And then there is an increased risk initially with this therapy and suicide. So you want to take a careful history there. And you can see common side effects. And it is pregnancy category C. If a woman is doing well on this and becomes pregnant, you don't have to take her off of it, but there is increased monitoring. I'm going to skip a lot of this. I will say that the oral formulation, the Revia, is really not used for opiate use disorder. Adherence is really low with this therapy, so people want to get high, they just don't take their pill for the day and they can use and get high, versus the injectable form, which is branded Vivitrol, which is a monthly depot injection. The big barrier to my patients accessing this medication is cost. Some insurances do cover it, but not all. Again, when my patients aren't pregnant, they don't have Medicaid access. And so again, getting this paid for is difficult, in addition to getting their liver function test if they don't have regular care. And again, naltrexone is not something we're going to start in a pregnant woman. It is standard of care to co-prescribe naloxone for anyone on maintenance therapy. And so you can see a couple options there. And we can talk a little bit through this case, but I want to make sure we have time for questions and double check the chat. This is a patient at one of the treatment programs that I work with. It's actually a compilation of a number of patients that I've seen over the years. And she's in our Women's Helping Ourselves program, which is basically allows women to come in who would otherwise be serving out a probation or parole, probation, to come into treatment with us and avoid some jail time. So she's 7 months pregnant, no prenatal care, was in on a paraphernalia charge and using IV heroin daily along with marijuana and cocaine and methamphetamine kind of weekly. She doesn't have a place to stay and she's unemployed. And so we really function in our treatment environment on assessing strengths and needs. And you can see she's had significant trauma, likely undiagnosed mental health disorders. And this is not her first pregnancy. So she has a lot of risk factors for this pregnancy and a good outcome and getting into long-term sobriety. So really thinking about her needs, we have prenatal care. Certainly we want to link this person sooner rather than later. Substance use disorder treatment, including medication treatment, legal aid, housing services, employment services, and then mental health services, parenting skills, and transportation. We do know comorbidities are very common, and I'm mindful of our time. And we know that trauma is very common in our patient population, so having a trauma-informed program is key. So how do we decrease stigma and help increase acceptance for women with opiate use disorders who are pregnant or postpartum? I think language really matters. And even our talk today is titled Medication-Assisted Treatment. That is falling out of favor. And just simple treatment or medication for the opiate use disorder is now the preferred terminology. And certainly we don't want to start stigmatizing infants at birth with being quote unquote addicted. So an infant can be physically dependent on opiates from in utero exposure, but they are not addicts. And then again, the focus on strength and holistic care, trauma-informed, strength-based therapies, kangaroo or close skin-to-skin contact care in the perinatal setting, rooming in when that's possible, breastfeeding support, and then the chronic disease model for opiate use disorder care. So once the woman delivers with opiate use disorder, supporting her in her long-term recovery and including in that support medication treatment for her opiate use disorder. I do want to mention the Mommy's program as a model for this. And this really connects pregnant persons with OUD to prenatal care. There are treatment services, including medication therapies, and ideally this is integrated or co-located. So I know our Mommy's program at Santa Maria Hospital, we work with OBGYN at our local county hospital at Ben Taub, and they now have several waivered OBGYNs that are part of that program. So a woman can go for her medication treatment of her opiate use disorder visit along with her prenatal visit, and it's the same person giving her that care. The Mommy's programs around the state provide education and support of labor and delivery, neonatal nursery nursing and staff on opiate use disorder and fighting stigma, because a lot of our patients face that in their treatment, and long-term engagement of families and opiate use disorder treatment and recovery support communities. And we see outcomes from the Mommy's program include decreased neonatal abstinence syndrome, decreased maternal relapse, and increased stability of families. And I want to leave you with just a few slides on finding treatment, and these will be available for you after the talk today. Again, highlighting the new MARA 12-step program or 12-step organization, which is Medication Assisted Recovery Anonymous. So some folks might find that to be a better fit than traditional NA groups, although there are fewer groups available. And there's some references that were used for this talk and some resources on staying current. I'm going to stop screen share so I can see chat more easily and respond. Excellent. So we hear, I hear from another program. Alpha Home in San Antonio has a mommy's program. That's wonderful because it really does help integrate everything for that woman and all the things she's going to need to support a healthy pregnancy and a healthy first few years for her recovery and her infant's development. What factors contribute to the prescription of one medication over the other? So in terms of buprenorphine versus methadone, again, oftentimes it depends on access to care. There aren't as many opiate treatment programs available, particularly in rural areas, but even in urban areas, they tend to be concentrated more in the urban core. And so someone in the suburbs may really find it hard to attend a program where they have to drive 30 or 40 minutes through traffic every day to pick up their medications and get their treatment. So that can be a factor. Sometimes, you know, someone needs that accountability of being able to, having to go every day to a program to get their medication. Maybe they've been in a buprenorphine-based treatment program with their physician, their primary care physician, their OBGYN, or in a treatment program, and they find they can't maintain their sobriety. On buprenorphine, they're still having cravings and withdrawal, even on max doses of buprenorphine, then they would be a good candidate for methadone as well. Or if they've been found to consistently divert their medication, they may need that extra accountability. So let's see, for individuals diagnosed with a behavioral or mental health disorder, are there special considerations? So antipsychotic medications, we don't see a lot of drug-drug interactions with that and with methadone or buprenorphine. With someone who also is HIV positive and is on medication to control their HIV infection, we do see some drug-drug interactions there, so it's important to work with their HIV treatment provider. And the good news is that more and more HIV treatment providers are actually getting waivered, so they can integrate that care for the patient. But we don't see many drug-drug interactions with either buprenorphine or methadone and other psychiatric medications. Let's see, we talked about morning sickness. Can you talk more about how buprenorphine is used outside of OTPs? So again, if you're hold a DEA certificate and you're able to write for controlled substances, so you're a DO, MD, PA, and nurse practitioner, you take your waiver training and you meet the criteria, you don't have to be in a specialized treatment program to do this with your patients to start prescribing. So this can be done in a primary care setting, the OBGYN's office, etc. Other questions, and feel free to come off of chat and just speak up now.
There was one about a fatty liver. There was is there a problem with fatty liver and taking the medication?
So with buprenorphine, not particularly. With naltrexone, you'd want to watch the liver enzymes, and generally we accept, sometimes we'll see a modest bump in the liver enzymes, so something like 2 to 3 times the upper limit of normal, we'd probably just monitor. If someone went to 5, 6 times the upper limit of normal, then we'd be more concerned and might pull them off of that. Anything else? Other questions?
I think that was it.
Okay, well, thank you. I hope this was helpful. Thanks to everyone for tuning in.
Thank you so much. We really appreciate your time, and you have a wonderful day.
You too. Bye.